My name is Samara Bogwa, and I'm the president of the Alumni Board here at NYU's School of Global Public Health. On behalf of all of us here and the Alumni Board, thank you so much for joining us. We're so excited to have you here as we kick off our Alumni Weekend events. It's a privilege to introduce our moderator today, our dean, Dr. Debra Furr-Holden. Started with GPH just 3 short months ago, but has already made such a huge impact. She is a renowned public health professional with expertise in a variety of areas, including health disparities, health equity research, policy and practice, drug and alcohol dependency, psychiatric epidemiology, and last but certainly not least, prevention science. So please join me in a warm, warm welcome of our new dean, Dr. Debra Furr-Holden.
Thank you, Samara, for that kind introduction and your great work. I want to acknowledge some other key members of our alumni board who are here, and some are not in the room, but their work is invaluable. And that's Victoria Good, Deron Kidd, as well as Manpreet Sachdev. Just thank you for your great work on our alumni board. Good afternoon to all of you, and welcome to the School of Global Public Health. What a beautiful building and beautiful space, right? I've been known to go off script, so I'm going to go off script for 1 second. And I want to acknowledge a big accomplishment in this school. One of our amazing faculty in the chair of Public Health Policy and Management was just inducted into the National Academy of Medicine, Dr. Jose Pagan. Yeah. So myself and other leaders here, anybody that is an alum, a faculty member, or a student, consider them somebody that you can talk to about what's happening here. This is our first Alumni and Parents Weekend since the building opened. And it is really an honor for us to host you all today. And I'm excited to moderate this, what I know will be really exciting discussion. So let me tell you just a bit about who I have with me. We have Dr. Laurie Zephyrin. Dr. Zephyrin is the Vice President for Advancing Equity at the Commonwealth Fund. She's gonna start us off. I also have Dr. Ann Marie Beddoe. Dr. Beddoe is a reproductive specialist. She's a gynecologic oncologist.
Got it.
And then we also have, and she has the great distinction of being an NYU GPH alum. And then we also have Dr. Helen Landaverde, who's the CEO of New York Health and Hospitals, Elmhurst, and also a proud NYU alum. So welcome our panel. Just a couple of insights to sort of lay the foundation and get us started. Being pregnant in the US carries some grave risk, health and safety risks. In fact, research shows that a safe and legal abortion is actually 14 times safer than childbirth. According to the American College of Obstetricians and Gynecologists, homicide is the second leading cause of injury-related deaths among pregnant women, and the majority of those homicides are carried out with firearms. Women in the US who are likely to be killed by an intimate partner are more likely to be killed by a gun than any other means. So while the politics surrounding abortion in the US is at an all-time high, those in the field of public health know that we've got to keep our eye on the ball and stay squarely focused on the fact that the health of women, especially those in the most vulnerable communities, is now in the crosshairs. To help us better understand just what that risk looks like, I'm going to hand it over first to Dr. Zephyrin. She's going to discuss the national landscape and the shockwaves caused by the Dobbs decision. She's also going to elaborate on the role of philanthropy, and she's really steeped in that, right? She's coming from the Commonwealth Fund and helping to drive policy agendas related to women's reproductive health. Dr. Zephyrin.
Thank you. Thanks for having me. Thank you, Dr. Furr-Holden. You know, this is just really a critical moment in our society, in our field. I mean, as I think of my work clinically as a physician, focusing on influencing health systems and health policy, you know, and thinking about how we can utilize new models of care to advance health equity in center communities, this is just such an important decision, right? Because I really think about how systems and policies can really advance health and health equity. You know, this is really the first time a constitutional right has really been taken away. And never in the history has really the Supreme Court ended a basic constitutional right. And so what's new about this conversation is that we're also talking about power, we're talking about control, and we're talking about linkages to other rights, such as reproductive justice, economic justice. Dr. Furr-Holden talked about also who's affected, poor women of color, women who are immigrants. Those are people who are most likely will be the severest affected by the Dobbs decision. And why is that the case? This is because, they face the greatest economic barriers to securing an abortion in states that still allow it, and because they face the greatest economic hardships from unplanned pregnancies, for example. And this hardship is magnified by lack of insurance coverage in most of the states, and for undocumented people in particular. It'll make the lives and the lives of their families far more difficult than it is economically. It also makes people extraordinarily vulnerable, right, to poor health outcomes from pregnancy and complications that may go untreated because of it. And when we think about this national landscape, and you alluded to this in your opening comments, more people in the United States compared to other developed nations die from complications of pregnancy and childbirth than any other developed nation. And most of these are preventable, and the rates are on the rise. And that's just mortality. When we talk about morbidity, there's just magnitudes among magnitudes of impact that we see. And those who die and experience these inequities are more often than not Black people, Indigenous people, and really the birthing room being another place where systemic racism takes its toll on Black and brown lives. So on top of that, we have to think of the root causes of this. You can't separate what we're experiencing from the Dobbs decisions from the crisis and the lack of investments in overall healthcare and lack of access to healthcare. Healthcare is unaffordable, the uninsurance rates as well, and also lack of access to childcare, education, and social infrastructure. And so when I talk about the shock waves, we have to really understand the interconnectedness of all this. And as we think about solutions, we also have to address those interconnected pieces as well. There's been a steady drumbeat of actions to limit abortion access, right? And this is obviously a fatal blow. In many ways, it inserts the government into people's private and most personal choices. And we've given power and control to states who can decide whether to prioritize equity or not. Reproductive services are inaccessible to many families, fewer options to healthcare providers, anxiety and fear being created, and hesitancy to seek, people be able to seek and provide care in states where abortion is criminalized. And it's difficult for healthcare providers to do their jobs and care for people as well. And this also increases the long-term risks to the life and health of children. Since evidence really shows that children of unintended pregnancies are more likely to suffer preterm birth, low birth weight, impaired child development, and adverse childhood experiences as well. And, as I mentioned earlier, given the racialized distribution of poverty, of discrimination, of lack of access to high quality care, any systemic failure or shortcoming in the U.S. is felt most acutely by those most marginalized. So we have to understand when we say that this is more likely going to affect poor people, people of color, young people, it's because of the racialized distribution of the social and economic impacts in our society. So then the question is, how do we make the impact? What's the right solution? What's the best time? And we have to think sort of short game and long game, because while we wait for the best time, people are losing their lives and people are suffering today. And so coming to the lens as a physician, as someone steeped in systems thinking, as someone in philanthropy, we think about this from the top down. What are policy changes that we can impact that address some of the shock waves? How can we address access to health insurance, access to reproductive health insurance? How can we affect access to child care, for example? And then from the bottom up, how do we help people today dealing with these, living in restrictive states and dealing with sort of these layers of oppression? How can we affect access to abortion services? How can we shine a light on the equity impacts of this work? Because it's really critical that the impacts of this aren't just in the dark. People need to see and understand how people's lives are affected by this. And, I think one of the other pieces that I'll close with for my comments is, when we think about those states that are more likely to ban or restrict abortion, we know that those states that ban or are likely to ban are most likely the same states who fail to adopt Medicaid expansion, right? Are the same states who have the highest childhood poverty rates, are the same states that have more pregnant and birthing people who lack early and adequate timed prenatal care, the same states where we see the highest mortality, maternal mortality and infant mortality rates, the same states where there are already shortages of maternity care providers as well. So again, when we think about the layers and layers of this impact, it's truly significant, as all of you know, and we really have to think about the solutions and as something that's very holistic and something that isn't just going to happen today.
Wonderful. Thank you, Dr. Zephyrin. So I always tell people there's an almost certain predictable future, right? And we sort of can get a glimpse of what that future would look like because we've got people who've been practicing before Roe v. Wade, during Roe v. Wade, and so it gives us some insight in what things might look like. So Dr. Ann Marie Beddoe has been working in New York hospitals before and now during the Roe v. Wade era. So she's going to really share with us about what this meant for women's reproductive health and kind of give us a glimpse of what it might look like as we maybe regress in the progress that we made in these reproductive rights.
Thank you, Dr. Furr-Holden. It really is my pleasure to be on this panel today. And since most of you in this audience were not born around Roe versus Wade, I'd like to pivot and go back to a little bit of the history of when this law was passed. So despite early 19th century laws that restricted and criminalized abortion, the New York State Legislature in 1965 amended the statute that made abortions illegal and allowed the states the flexibility to then abort under the terms of therapeutic abortions. In 1970, under a Republican governor, Nelson Rockefeller, the New York State Legislature passed a law that most cases of abortion became legal despite opposition because the governor vetoed most of the opposing views. New York State, we should know, was the second state after Hawaii to enact legal abortion up to 24 weeks. So 3 years before the constitutional right to an abortion was upheld, New York led the country in providing availability of these procedures. With the most liberal abortion laws in the country in 1970, over 400,000 women flocked to New York City looking for abortions. The majority of these women were white women. They could afford abortions, and many of them, at least 2/3 of them, really came from out of state. Many Black and minority women lacked the accessibility. The availability was there, but the accessibility was missing. And so socioeconomic factors like poverty, stigma, humiliation, lack of transportation, as well as fear of attack by those anti-abortion activists resulted in the most vulnerable women in our city continuing to seek illegal means to abort. In 1973, the Supreme Court passed the landmark decision, Roe v. Wade, legalizing abortion. The case, which was initially filed in 1968 by lawyers representing Norma McCorvey, aka Jane Doe, culminated in 1973 with the passage of the law to protect a woman's right to an abortion under the Right to Privacy Clause. Despite this, illegal abortions, although they had dropped in number, they still continued with grave reproductive consequences. As a medical student and as a resident during the pre- and post-Roe period, I witnessed the medical carnage that accompanied illegal abortions in New York City. I was working at a busy city hospital in Brooklyn. Many of the clandestine abortions, the so-called back alley abortions, were performed on a majority Black and immigrant population who could not afford the procedures in the hospital setting. Untrained or partially trained personnel used various devices, including knitting needles and coat hangers that were inserted into the uterine cavity, allowing the fetus to abort. Many women performed home procedures because they couldn't even afford the illegal abortions, and the coat hanger was really the instrument of choice. In addition, women tried self-inflicted trauma, like throwing themselves down stairs or jumping, or ingesting various so-called push medications. The complications of these procedures were really multiple and horrific. Because many of the personnel performing procedures were untrained, perforations of the bladder, the intestine, and the colon were common. Young women had to be operated on with total or partial removal of their affected organs, resulting in colostomies, or even worse, the loss of their uterus. And that was just the tip of the iceberg. We were guaranteed at least 3 admissions from the emergency room every night from women who had complications of unsafe abortions. It was not uncommon to examine a woman in the emergency room and discover 2 to 3 feet of bowels sitting in her vagina. Our hospital wards had isolated areas that we referred to as the septic abortion units, where patients' temperatures ranged from 101 to 106 degrees Fahrenheit. I had a patient who became deaf after heavy doses of antibiotics, and one who inserted bleach into her vagina in an unsuccessful attempt at abortion. The morbidity and the mortality rate were high. It is estimated that we lost about 1,000 women each year in the US from unsafe abortions, representing a very large portion of maternal deaths. These were the complications we saw and treated, sometimes successfully and sometimes to no avail. What we could never really get a handle on was how many of these women became sterile after attempting an unsafe abortion, losing their capacity to ever reproduce again. Should the additional plans to block the use and sale of misoprostol and other forms of medication abortion come to fruition, we will undoubtedly return to these times. Laws criminalizing abortion do not stop abortions from being performed. They just increase the number of illegal abortions. So, in closing, I spoke yesterday with one of my mentors who performed abortions in the pre-Roe setting. He reminded me of the many complications that were averted by providing safe and sterile procedures done under New York state law. So I'm obliged to quote his 2080 statement. It was really his foresight. He said, "At the end of my career, they're trying to change it back to what it used to be. I never, ever in my wildest dreams thought that we would be facing what we face now." Dr. Carmel Coing, Professor Emeritus of OBGYN.
That was a history lesson. Amazing. Thank you for that. I got a real history lesson. And I will tell you, as the dean, I'm trying to figure out where the line is for me. So I've steered away from the word reproductive rights. I know you got me too. Because I didn't want to get in the crosshairs of the craziness. But listening to you, that's our job, is to be bold and get in the crosshairs. So I've been talking about women being forced to carry unwanted pregnancies. But these are rights. A woman has a right to choose when she is going to be a mom or when she's going to go through with the pregnancy. It is a reproductive and a birthright. So I'm no longer going to call it something that's more palatable to people. Not after that history lesson. We will call it what it is. It's a woman's reproductive and birthright. Say that on the mic, Dr. Zephyrin.
And it's justice.
She said, and it's justice. Woo. Thank you. So Dr. Landaverde, no pressure. So Dr. Helen Landaverde, she's going to discuss how Elmhurst Hospital specifically is responding to the Dobbs decision, including Governor Hochul's recent announcement of nearly $13.5 million in state funds to expand termination services. So Dr. Landaverde.
So good afternoon, everyone. So first, I think we should all, after that history lesson, really thank all the physicians and the women that stood by other women in their moment of need and time. So I just want to honor that as well. And I also want to make sure that we all know that, again, in the history, New York stands up again. New York, when the reversal was done, our governor said, no, this is not going to happen in New York. Right away, within a week, it became part of our New York State Constitution that women have a right to choice. At the same time, she also put her money where her mouth is. Because one of the things that we realized right away is this issue of access, this issue of education. What is going to happen when this goes full-blown throughout the states? Where now our constitutional right was taken away to 51% of the population. What are health systems going to do? What is a public hospital going to do? How are we going to train our providers on something that no other states might be doing? How are we going to work with payers that all of a sudden say, no, we do not cover reproductive rights. We don't cover abortions. We don't cover family life. We don't cover the medication for termination. We don't cover the ultrasound. We don't cover Plan B. How do we work around those payers? Because one of the things we often forget is that now payers are international, are national. So they cross different borders. And then at the same time, what do we do with our women? What do we do with the patient? How do we address their needs now in the short term? So I'm very happy to say that Elmhurst Hospital not only has doubled their services of terminations, but we've also have reached across the state lines and kind of said, hey, if you have providers that want this training, we're here to help. We've also educated our women on how to get access to the health. Also, we've educated our doctors, our staff, our nursing on this issue, because I have to tell you, at Elmhurst, we were a little shy, but after that talk, I'm like, no, it's our reproductive rights. We were like, oh, we called it family planning. You know, now we're not going to call it that. Now we're going to say, no, this is your reproductive life. You get to choose. You get to choose. And here at Elmhurst, we will not judge you at any of our public hospitals. So what we're doing, we're taking this funding and we're using it to educate. We're using it to advocate. And we're also using it to increase services. So now our hospital, we used to provide termination services 5 days a week. Now we're having evening hours, and now we're doing Saturday hours as well. And at the same time, and it's not only having the patient come through our doors or our women come through our doors, we're doing the full continuum of care. After you come through our doors, you have your choice. We give you consultation. We do the follow-up. And then we say, hey, what do you want to do for your family planning? What is your long-term goal? How do we teach our women to figure out their own bodies? Because these bodies change quite often. I'm telling you, I hit 40s and I don't know what happened. But more importantly, I think this New York again is standing up. And for the short-term goal, we have a plan. And I think for the long-term goal, I think the fact that all of you are here is a big sign, not only for what public health is going to do, but also what public advocacy is going to do. I think the long-term goal, what we need to do is stand together for each other, because women are 51% of the population. And women are also leading the workforce. Out of every 10 women, 6 are working in the workforce. Out of those 6, 4 are head of households. That's a lot of power. No offense to my men here. But that's a lot of power that we have, and we have to get back our rights.
Thank you for that, Dr. Landaverde. You say a lot of power. That feels like, as a female head of household, a lot of responsibility, right? And that responsibility needs to be shored up with the protection and preservation of all of our rights. So, amen. All right. We want this to be interactive. This is the opportunity for you all to chime in. We've got mics on either side of the room. If you don't want to get up, you raise your hand. Somebody will hand you one, and you can go to the mic also. And we welcome you. We want you to ask questions and interact with this great panel. I'll start. Go ahead. No. I'm here for you. I'm the moderator.
Okay, so I wanted to ask a question.
Can you put the mic real close to your mouth so everybody in the back can hear you? Make sure it's on.
It says it's on. Can everyone hear me? Okay, this is better. Yes.
Okay, great.
So you mentioned, Dr. Arteaga, that, looking at payers, they're national. How does that look like in terms of coverage, and how that would work out on maybe that platform?
So when it comes to payers, we have to also advocate in a certain way. And the way you advocate when it comes to a payer, it goes by your choice. So when, 76% of the population gets their insurance through their employers, right? And they give you a panel and they say you can pick Aetna, Blue Cross, Metro Plus, whatever the cases may be. It is our job to understand when I apply for Blue Cross Blue Shield that I do not have access to termination services. Sadly, the onus is on us, but then when you know that fact, you have to pick a plan that does cover you. And sadly, we have to do our homework. And the only way to show payers that women's choice matters to us when we're picking a health plan, because you're not only picking a health plan for yourself, you're usually picking a health plan for your family and your children. And also because most women are caretakers as well, and the gray civil wave is coming, so we're taking care of a lot of our parents. We're also picking for our parents. And there is power in choosing your payer. So if you sent the message of no, I'm not gonna be in this payer because they don't cover terminations, I'm gonna be on this payer, and your one choice brings 5 people into their lives, into their insurance coverage, that's 5 people less they have, and that's gonna hurt their pockets. So we literally have to advocate by choice through them, because at the end of the day, the payer side is an economic side. Dr. Bagan will probably agree with me here since he's head of economics there. But, it's a plus minus for them to cover the healthcare system. So that's what we have to do with them.
Great, thank you.
Hi, I'm Erin Hartnett, nurse practitioner, founder of Nurses for America. And I just want to ask everyone here, are you registered to vote? In 2 weeks, we have very clear choices about people who will protect our reproductive rights and those who won't. So just make sure that you make the choice that's right for you and for what you want. And if anybody needs help registering to vote, I'm here, I'll help you.
Thank you so much for that. Thank you. Oh, I thought you were going to ask a question, Julia. So I'm going to follow up on this payer question. We have somebody in the audience?
The last statement was, I use my principal voice. The last I had here was 51%.
The mic will help for the recording also.
And for me, that's a huge one, because it doesn't make a difference if you don't vote and if votes aren't counted. Obviously, being Black, that has affected our community a lot, as far as registering, getting things taken away, the right to vote, health care, education. I'm a principal. So they warned us that if the Supreme Court was taken over, the litmus test was Supreme Court judges who will terminate, excuse the pun there, Roe v. Wade. We know Lindsey Graham's whispering national next. They're telling you. They're telling us. And the 51% of the population, I believe, is very important, because that 51 could be, depending on the state you live in, can be muted, and that number can be dwindled in certain states where certain people can become the terminators of. I'm from Delaware. Next door, we're looking at a state where you can have a governor who's going to determine, what votes count, and so it's local, state, and national. And that's where we're all coming from with the national. It's coming down. And the big part about, with states that the states that need the most have the less. And it's not funny, but we know what goes on in those states with racial politics to have people vote against their best interests, particularly in the South, and that whole dynamic. So racial politics is a big part of this, which affects voting in general And percentages specifically, 51% doesn't mean that. For example, in Delaware, we have 3 counties. The bottom 2 counties are totally red. The top is blue. And they are going after school boards. They're going after local. They have a lot of money coming from outside. Matter of fact, I don't know if I'm putting some history in here. I love history. Mike Castle was the canary in the coal mine back when the witch lady ran against him. He was a moderate Republican. They ran against him to get him out with money. And that was the start of a lot of what you see as far as the politics and voting and the Supreme Court and the national and state level. And I just think that 51% is very important, and voting is very important. We all register, we vote early, but it's incumbent that everyone you know has to vote, or none of this is going to change. It's going to be national next, and they told us that. So what we're going to, how did this happen? Just like we are now, how did this happen? They told us. That. So that I just want to focus on the voting part, because that is huge, particularly with history. And coming from my demographic and voting, we were just allowed to vote in my lifetime as a Black American in the 60s. So it's important.
Thank you, Principal. No, it's great. So there is power in the vote. I say there's power in your voice, your vote, and your pocket. And I love the example that you gave. If people don't choose payers who don't provide termination services, that's a factor I never even thought about. I don't want a payer that doesn't provide termination services. Now, I think it would be a miracle if I were to get pregnant at this age, right? I'm a grandma, but that's a way that we can be, because I'm always asking, and people are always looking, what can I do? Like, who could I do and what could I do? So that is something that people sitting in their chairs right now could do. We could send a message to payers who don't pay for termination services, whether or not you plan on using them. We could starve them.
Amen to the principal.
Yes.
And yes with the payers, because nothing says a quicker message, because we are a democratic country, but we're also a capitalist country. And we also have to be very clear that healthcare was born in, we want to believe healthcare was born in a socialist model, but it wasn't. It was born employer-based. It was born out of industry saying, how do we keep our employees healthy so they can keep working longer? That's why 76% of our insurance come from our employers. So this is the power that you have. And just coming back to like our reproductive rights, I think for me as a mom, when I think of my daughter and how she has less rights than I do, I think it's very sad that I have to limit her. That let's say she has, she loves art, and let's say there's a beautiful art program in Utah or in Texas. I literally have to tell her, well, you can't go there, because your rights are less there. What kind of message am I sending to my daughter that I already have limited her in her dreams? And that's something that triggers me, and I'm like, oh, I'm not gonna let this happen. So the advocacy that we have to do with each other has to be not only here for New York State, but also nationwide.
Hello. I have a question. So we heard about how New York is leading the charge and offering supportive structures. But I would like to understand what's happening in those states where access is still such an issue. What are you hearing from your clinical colleagues about those access issues?
I can start and then pass it along. I mean, I'm hearing a range of things. So one, I'm in terms of, I think I mentioned in my opening comments, what we see about those states that ban or most likely to ban abortion. There's other shockwave effects as well in terms of limited access to, there's limited Medicaid expansion, et cetera. We're, just in talking to colleagues and others in those states, we're hearing a lot of concern from providers in terms of inability to do their jobs, fear of being criminalized, and in really the workforce issues are significant. I heard from residents the other day or medical students that aren't looking at certain states to learn how to practice because it'll limit their access to learning how to do some of these procedures. And one of the important things to understand about the procedures we're talking about. I'm an OBGYN, like those procedures we do for a range of things. It could save a birthing person's life if they're bleeding a lot during pregnancy. And so, or it can help with people that are having miscarriages. So people not learning or those procedures can just have significant effects on their ability to care for women and other birthing people. Also, just in terms of what's happening, there's just, I think, so much innovation and thinking that's happening. So I don't know if you've heard, there's like a movement around creating abortion funds, right? A fund being created to help pay for people to travel to the neighboring states. Recent announcements about, Planned Parenthood, for example, moving clinics to the border, to border states, for example, so that people can cross the border to receive services to healthcare for healthcare and other abortion and reproductive health services. There's a lot of conversation you've probably heard around access to medication abortion, which is very safe, used globally. And so really having more widespread use of that, being able to provide that via telehealth, for example, and create access to that. So those are really really important areas as well. One of the areas which I've also been talking more about and hearing more about is this intersection of philanthropy and venture. I mean, you talked about capitalism, but what are ways to be able to support organizations out there that are doing this work, to be able to infuse funds to help support that work in a meaningful way. There are even organizations and companies that do gender equity investing. And so being able to decide, which companies to invest in and creating access to these services as a measure of gender equity. And so we're seeing more of that and more of those conversations as well. But it's, it's interesting. Some of the work that we've supported at the Commonwealth Fund, we actually have funded, for example, there's a reproductive health reporter there now who's really trying to tell the stories of people on the ground in terms of what's happening and what are they experiencing, because we need those stories told. Gulf Coast News in Mississippi and other states, they're also doing some reporting on the ground as well, so we can get stories from people in terms of what their experiences are, so that their news doesn't stay in the shadows. So there's a lot happening. I think there's a lot that needs to be done.
So if I can just add, I think talking to colleagues, the biggest fear is that if you perform an abortion, even if it's a life-saving abortion, that you would have committed a felony. And if we think about this full circle, if Florida gets its way, if you have a felony, you can't vote, right? So that actually decreases your power to have an input into what happens to women's reproductive rights. And so that has been the biggest issue. I travel to low and middle income countries, and I always prided myself in saying, I'm so sorry, you guys, that abortion is illegal. Our patients in low and middle income countries would never give up the name of their doctor. They come into the hospital bleeding, and you try to find out who did this abortion. They will never give up the name because they know how vital that person is for the next person who needs an abortion. Here, our states are saying, you give us up and you will get money for it. So we really have to think of all the implications to all these activities that are going on a very high level that we are being left out of.
Yeah, we're hearing, from my providers, we're hearing the same thing, and we're seeing our residents not picking matches or going into certain fields because they're afraid that they're going to get, in trouble, or they're just so afraid that they're not even going into OBGYN anymore. So we're seeing something very similar also.
This is already on top of a workforce shortage of OB and midwifery providers in this country.
And you do want your providers to be well trained to do these procedures. And if you're not having the opportunity to learn and do these procedures, we'll end up being right where we were pre Roe v. Wade.
Hi. I was hoping some of you might be able to speak on this topic towards, trans individuals, non-binary people, other people in the LGBTQ community, and just how it's impacted them and access and whatnot.
Well, I can speak for, since most of my work is global, I can speak to the fact that trans people are really stigmatized, and they don't even go in for simple things like hemorrhoids. So coming in to ask for an abortion is going to be a big reach for a trans person or someone in the LGBTQ community. What is a little reassuring, and what there is some lining to the cloud, is that many centers are now putting in place institutes for taking care of the LGBT community, and hopefully within that in those institutes, that patients will have the opportunity to request abortions and have procedures done. Hopefully New York State, which has been really a leader in abortion rights, that is left intact.
I think this also instills a lot of fear and also exclusion, because when we think about the ripple effects, when we think about the impacts of intersectionality, whether you're LGBTQ and person of color and this living, all of that additionally adds levels of just fear and concern depending on where you live. I think the other piece that's really important is, when we think about erosion of rights, there's a concern of, is this just the beginning? And so people that are minoritized and are marginalized are feeling this even more because it just comes closer to home. And not having access to the healthcare services within your community that you can identify with, it just makes it extremely difficult and extremely challenging. So, my concern and what we're hearing and seeing is just, this is just continued effects and erosion of just our overall rights and overall justice. And it's something that that you feel more closer to home the more you connect with communities that are most marginalized and most minoritized. So I think this should be a wake-up call for all of us to really recognize just the risk and the impact that ultimately we're all experiencing.
It's just the beginning, people. It really is.
I have to say I'm very proud of our health system. Within our 11 hospitals, there is 4 hospitals that have an LGBT community health center where we do provide abortion services. And for our other hospitals like Elmhurst, where we don't have a dedicated center, the number one thing that we try to do for everyone that walks through our doors, Jackson Heights has the second largest after here in the city, the second largest LGBT community. What we try to do at least is to provide a safe environment from everywhere from the guard at the door or like the receptionist, the doctor to the nurse, is really offering that hand that's saying, you are safe here. We can't solve everything, but we are here and we're going to do this together. And I think that's what makes public health systems a little unique. And because we're also very self-aware that this could also be only the beginning, I think having a safe haven and believing in our public system and our advocacy, I think is super essential.
Hi, I have another question. Before I start, I'm Emanuela Mensa, and I am a second-year GPH Health Policy and Management student. So I have a question surrounding coverage. In 2014, Burwell versus Hobby Lobby was passed, in which the decision of, reproductive service was put in the hands of the employers. Now we're having reproductive services being put in the hands of the states, do we kind of foresee an issue where more and more employers are now going to come and say, we don't want to cover certain reproductive services, just as we're seeing more and more states coming up and saying, we're putting a hold off of, reproductive services?
I think that is the risk when there isn't the whole purpose of a federal right is to create some standard, right? So that you're not in, Texas or New York or Florida and you have access to different healthcare. I mean, which we already do. And this is more so now. So I think that's a very important question in terms of, which you alluded to in terms of the role of payers and the role of employers, and their ability to dictate the healthcare services that people have access to. And without some federal protections on that makes that even more possible, meaning depending on where you work, there's a risk of you having certain services covered or not, which is already the case, and this expands that. So in terms of like some of our work at the Commonwealth Fund, just more broadly, we've been thinking about just the impact of Medicaid expansion, for example, of postpartum Medicaid extension, of having more states take up the ability to expand postpartum Medicaid based on the American Rescue Plan Act, right? And we see not all states have even taken up Medicaid postpartum extension, even though they're able to, right? And so part of it is, from our standpoint is, what's the research that can help drive that change? How do you help put that research in the hands of policymakers to be able to promote that expansion of coverage? What's the data and research that's needed to be able to drive policy and systems change? So for those of you that are students in the room, like there's a lot of work that needs to be done on all aspects. There's work that needs to happen on the ground in terms of the advocacy and being able to advocate for your rights. But there's also the, being able on the policy level to be able to help either be in the policy making seat, whether it's at local government, state government, or federal government, or also in the research seat, being able to utilize that research to help drive policy change and legislation. What you're raising is critical and very important in terms of just the role of payers, particularly in our healthcare system where payers drive coverage. I'd also like to say, just on top of that, also, the role of federally qualified health centers is really important. The role of organizations like Planned Parenthood and others, for example, to be able to provide those access to those services as well, so that if people's employers don't cover that or their states don't cover it, then what are other opportunities for people to receive access to the healthcare that they need?
Thank you.
Thank you so much for this talk today. I really appreciate it. I just wanted to comment on the question about the queer community and add to the fact that the unraveling of Roe v. Wade was based on what you do in your home, which also is how anti-sodomy laws were overturned in the past and was part of the basis for same-sex marriage passage. So I don't have an answer, which I apologize for, but I just want to drive home that it's intricately tied and that it does feel like this slippery slope that we're going down.
Are you a GPH alum?
I happen to be one.
Thank you for that.
I just want to say I stand corrected. You're absolutely right about October 14th. I just checked. The 24th is the day for absentee ballot requests. So I'm very sorry about that. But I have the list of other states, so I can help you if you need another state or requesting an absentee ballot. So I apologize for
No, thank you for that. And I always want to be honoring of our guests, but like sometimes you know what you know, because I was one of the people who missed the deadline. I didn't know. And so I did register to vote here. And if there's anybody who's not registered to vote, please still take the opportunity. And I did find out in Michigan, I have until November 2nd to get my absentee ballot. So I requested my absentee ballot. And after this election, I will then now be able to vote here in New York. And turns out my vote will mean a lot more in Michigan this year than it will mean in New York. So your point is well taken. Still take the opportunity. And again, thank you for being a champion that people use that power of their vote. Okay, I have one question. Does anybody else have a question right now? I would like to, whatever thought, you guys have given a lot. I mean, I've been writing notes the whole time. I'm the moderator. These are the experts. I'm like, I didn't think of it that way. I am getting fired up about what I can do as an individual, but I also believe in us acting at our highest calling and our highest expression. So I'm thinking as an individual, I don't even know what services are covered on my health insurance, which my two daughters, 20 and 24, are also covered under. I'm gonna check that out. And I'm thinking, as an individual, I'm not supporting plans that don't cover those services for other people. You're in the hospital. You've been in the hospital. You're now running a foundation. You're in philanthropy. Any thoughts you might have for people? What can they do sitting in their chair as an individual? You also teach in our at the School of Global Public Health, so you're one of our faculty. What should we be thinking about? What should students be thinking about? What could individuals be thinking about? What could people be thinking about in their workplaces? I just love the idea that I personally have left with a bunch of actions that I can take, because the question that I'm asking myself, if I'm acting at my highest calling, what should I be doing as a public health leader and as a dean? How do I use that voice to be bold and to instigate the sort of radical shift that's needed in public health leadership for us to be bold and take this on? Because it is not just a public health crisis. It is a crisis of justice and human injustice. So any thoughts you might have in addition to what you've already shared?
I think for me, if, as a CEO of Elmhurst, I'm always trying to see how I can push the bar. I might drive my board members a little crazy and my staff a little nuts. But I think if I were you sitting in the audience thinking like, what can I do? The number one thing you can do is not make it a thing. Like, it was so funny. Like I was always talking about like, no, it is reproductive life. Everybody has sex. Let's get over it. And sometimes when you have unprotected sex, sometimes we get pregnant. But at the end of the day, that choice belongs to the woman. And I think we have to stop making it like your choice, my religion, the politics of it all, the biology of it all. No, it's policy. It's what do you want your government to stand for? What do you want your government to stand for? Do you want a policy that's inclusive? Do you want healthcare access for all or just for a few or for 49%? And I think that's what we have to start asking ourselves. Take away all the ethics, take away all the biology, and come to the basics. When you're calling yourself a public health advocate, is it for everyone? Or is it just for few? And I think if we all answer that question ourselves, I think the advocacy will come up naturally. And the fighting too, and the voting.
I think one way that the younger ones in the audience can keep in mind is that if you inadvertently have unprotected sex, there is a procedure called a menstrual extraction. So it's before implantation. Well, it's at implantation, but before an embryo is developed. It's done in a doctor's office with a small tube, and they extract what would have been your menstrual flow. And that is one way of protection. It shouldn't be the way of your prime method of contraception, but accidents always happen. And so don't wait until you're 10 weeks pregnant to then get into a state where it's not legal. A menstrual extraction is done within 4 weeks or, when your period is due, just before your period is due, or right after.
Do you have to know if you're pregnant to have that procedure?
Well, yes, you should have a pregnancy test, so they won't do it, yeah. But it's not a developed embryo for those in the administration who want to go by life and no life. But it's a viable option, okay?
So when I think about, for those that are students in the room, so
how many students in the room?
Oh, awesome. Yes. This is great. So I love public health. I think it's so critical. And since COVID, there's a reemergence in society of the importance and understanding of public health. So I think at this stage, you're in many ways pluripotential. Like there's many things that you can do, and I think there are many ways to have change. The way I think about it in terms of top down, which is a lot of my work at the Commonwealth Fund, is like, how do I use research to drive policy change? And so in terms of research questions that are important to answer, I think it's really critical to highlight the equity impacts of this decision. How it's affecting people's lives. Like we need to be able to document that and communicate that in a meaningful way. It's going to vary by race, ethnicity, across states. It's going to be really critical. We need to document the outcomes. I think it's also important to help inform the narrative because narratives inform values, which inform policy decisions. And there's a huge a lot of disinformation that's informing people's narratives, right? And so how do you tell stories, not necessarily to glorify people's trauma on the big screen, but to really humanize the impact so that people don't sweep this under the rug, so that they truly understand what this means on people's lives. And narratives, I believe and know drive action and drive policy change. And then I think sort of in terms of, that's sort of the top down. And then in terms of the bottom up, I think it's also important for grassroots action as well. And solutions that center Black and Indigenous and LGBTQ communities is really critical. We have to truly center the quote unquote margins. And I say quote unquote margins because we're really not margins. People are marginalized, and that's something that's created, not. And so I think that's really important. And also, it's really interesting as you're thinking about public health. I think it's also important. Someone who's doing health policy and management. I think it's really critical to understand policy and management and the finance side of it. There's really some fascinating, interesting, important work going on that really thinks about the intersection of social impact and venture philanthropy and financing, because it's really important to understand both sides. What are the levers of philanthropy? What are the levers of financing that can really drive public health change in a meaningful way? And I think you all have an opportunity to think about that as you go about your work. This is really critical. This is watershed, a life-changing, just a societal changing moment that we're in. And it should be a wake-up call to all of us, and I think it is.
That is a great mic drop moment. I want to tell you all, I am so poured into out of this conversation. I had a shift in my chair as the dean. I got a new set of marching orders and a new way of thinking about these things. I want to honor you and just say, we appreciate you. Thank you for what you set aside to come here and give us these history lessons, these policy lessons, these very real understandings of what we could be doing. It's a contribution to me. It's a contribution to our people. We appreciate you. Give it up for our panelists, please. Yes. And I just want to end by saying thank you all for being in this conversation. Thank you for your support of the School of Global Public Health. For our students, thank you for giving us a reason to be better and do better. We are because you are. Know that we are here because we see something in you and the difference that we're trying to make in the world. We know that you will be the ones to make that difference. So you aren't standing on our shoulders, like we're kind of standing on yours. So I love all the students, appreciate you all. Thank you for everybody. Thank you to our guests. Thank you to our faculty and staff in the room. Yes, thank you. And thank you to the extraordinary team led by Julia Cartwright, who put all of this together. Thank you all.